Thank you ever so much, and it's a genuine delight to be here and to share some thoughts with you. So I'm George Sledge. I'm a medical oncologist. I'm a breast cancer doctor. I've been a breast cancer doctor for over 30 years. I've spent most of my career taking care of patients with advanced breast cancer. So it's truly an honor to speak to this audience, which has so many in it who are suffering from this disease. Let me start with a story, because I tend to view life in terms of stories, as I think many of us do. When I was a resident, brand new resident, my very first rotation was on an oncology ward. And at that time, a book had recently come out, which I'm sure many of the doctors will recognize, and perhaps some of the others in the room, called On Death and Dying by Elizabeth Kubler-Ross, which was one of the foundational books of the hospice movement. We had a young sociology student who was working on her PhD, and she decided that what she wanted to do was to come to the oncology ward and to learn how cancer patients were dealing with their imminent death. And she was going to spend an entire year on the ward talking to the patients. So one day towards the end of the day, I saw her with an exceptionally angry look stomping out of the oncology ward. And I said, "What's wrong?" She said, "I'm leaving." I said, "Why? Did we do something wrong?" She said, "No, it's the patients." I said, "What do you mean?" She said, "None of them think they're dying. They all think they're living." Okay. And I kind of shrugged and smiled, but it was an important lesson for me as a young doctor, and hopefully an important lesson today for doctors in terms of caring for patients. And that is to say that patients with metastatic breast cancer, though they are well aware of the fact that they have a dangerous disease that is likely to claim their life, don't view themselves as dying. They view themselves as living. I thought of this yesterday when I was in clinic with the patient who I was seeing for the first time. It was a woman who was around 60. She was accompanied by her daughter and two lovely granddaughters. She had presented with metastatic breast cancer, with disease in her lungs and in her bones. I think tragically misdiagnosed for a fairly long period of time, who was visiting with me for the first time to learn about her disease, to learn about how she would deal with the disease. And almost her first words to me were, "Dr. Sledge, I don't want to die. How long do I have to live? What can I do about the suffering I'm going through?" She has bone metastasis. And that first visit with a physician, I think, is frightening for patients, but also, I will tell you as a physician, also kind of frightening for doctors sometimes as well, because it goes to the deep well springs of who we are as humans, how we interact with each other, and what we do. When a patient like that comes to see me as a physician, I have certain questions that I always have to ask myself in terms of how I'm going to approach that patient's disease. I have certain things I have to say to the patient. My very first question is always, and this will sound odd, does the patient actually have metastatic breast cancer? Oddly enough, patients are sent to medical oncologists who don't have metastatic breast cancer, but who think they do. So one of the very first things that we do when we see a new patient, quite frequently these days, is to obtain a biopsy of a metastatic site, of a bone lesion or a liver lesion or a lung lesion. And we do that for a couple of reasons. One, I think, is first, there can't be anything more horrible in the world than being told that you have a disease that can claim your life. So a doctor better be pretty sure that you actually have that disease before making that statement. But the more important reason, and the reason that has been becoming exceptionally valuable in recent years, has been the understanding that breast cancer is not one disease, but rather a family of diseases. When I speak to my fellows, I liken it to, think of it as a boarding house in which a number of criminals hang out, okay? Some of them are mass murderers, some of them are petty thieves. They have to be apprehended differently, and they have to be punished differently. And you actually have to know something about that to be able to do that. So when we obtain a biopsy in a patient with a recurrent breast cancer, a really simple reason that we're doing it is for that information gathering purpose. What is making this cancer tick? What is making this cancer dangerous? How can I intervene in terms of treating this cancer? So when we obtain tissue from someone with a metastatic disease site, one of the very first things we'll do is ask the question, what's driving the growth of this cancer? Is it being driven by estrogen? Is it being driven by HER2? Or is it, in the case of so-called triple-negative breast cancers, being driven by I know not what? Having that very basic knowledge is a first step in terms of developing a treatment plan that hopefully will allow the patient to live many years and to live well. This is changing, by the way. What I've just told you, I could have told you 10 years ago. But I think we are right on the cusp of a diagnostic revolution in terms of how we look at human cancer. And that is to say that as a result of advances in genomics, our ability to look at the DNA fingerprint of a cancer, we're now at a point where it's possible to look at every single mutation in a human cancer cell. And this, I suspect, will give us increasing power in coming years to actually treat metastatic cancer. I'm a great believer that knowledge is power. I think it's one of the foundational statements of the scientific revolution. Knowledge is power. If we know more about a cancer, if we know more about what makes it tick, if we know what makes it resistant to the drugs we use, then we should be able to come up with a solution to that problem. And the price of being able to do this has collapsed in recent years. The first human genome was announced to the public in, I believe, 2001 at a price of $3.2 billion for one human genome. We're now at a point where that price is approaching $1,000, probably sometime in the next year or so. Now, I spent 2 hours in an emergency room getting some stitches in my forehead a couple years ago for $1,000, okay? Which is ridiculous, by the way. Like everything else in medicine in terms of the cost of everything. But we're approaching a point where the price of being able to know exactly which mutations are causing your cancer to grow and change and become resistant is approaching that price point. And at that point, which I think is going to be reasonably soon, we're going to know a whole lot more about every single cancer that we have to deal with. So when I get those initial diagnostic biopsies, partly I'm learning about how to treat a patient today, but I suspect also, and this is certainly the case in research groups all over the country, we're learning how to treat patients tomorrow. Because the diagnostic revolution, I think, actually is going to be an important part of the therapeutic revolution that we're going to go through over the next few years. Now, I mentioned that when we look at patients' cancers, that we're not dealing with a single disease, but rather with a collection of diseases. And those diseases go by names such as estrogen receptor positive breast cancer, HER2 positive breast cancer, triple negative breast cancer. What is important to know is that because these are separate diseases, they have to be treated in separate ways. Learning about that, learning about how to treat those diseases in the separate ways has been the great adventure of cancer research over the last 15 or 20 years. If we were to go back to a point, say, 15 years ago, breast cancer was fairly straightforward. We tended to treat pretty much everyone with the same treatment most of the time. We used the same chemotherapy drugs for everyone. About the only differentiator we had for therapy was to give hormonal therapies to patients who had estrogen receptor positive breast cancer. The number of therapies that we had available to us was limited. the therapies that we had were quite toxic. The palliative care that we had to go along with them was quite poor. And the end result was therapeutic failure, frequently at an early point in time, frequently accompanied by progressive toxicity, frequently accompanied, I would say, by a sense of doom surrounding any interaction between a physician and a patient. There's still much of that, but I think we're also at a point where things are beginning to change at a fairly rapid pace. The Food and Drug Administration, over the last 3 years, has approved something like 10 new cancer drugs per year, each year, for the last 3 years. Now, those aren't all breast cancer drugs. They're not all drugs that we can use for patients with metastatic breast cancer. But it does give you some idea of the pace of research that is going on. We've, in essence, sort of turned on the fire hose of new drugs that are boiling out over the whole area. Among estrogen receptor positive patients, we have new agents such as palbociclib and everolimus, which have just come along in recent, just literally in the last year or two, which we think are changing the landscape for patients with metastatic breast cancer. Palbociclib, for instance, and you'll be hearing more about this later, is a drug that, in essence, shuts off the piston that cancer cells use to drive the growth of estrogen receptor positive breast cancer. Adding that drug to a standard hormonal therapy roughly doubles the length of time a patient will remain in remission for metastatic breast cancer, and we think that will be just the first of several such drugs that will be coming along in the fairly near future. In HER2 positive breast cancer, the addition of novel monoclonal antibodies such as TDM1 for patients with metastatic disease and pertuzumab or Perjeta for metastatic disease have significantly improved the survival of patients with metastatic HER2 positive breast cancer. Triple negative breast cancer, I think, has remained a major problem. Show of hands for all of you who have triple negative breast cancer or know that they do in the room, okay? A reasonable number, okay. These are cancers that historically have lacked targeted therapy. They are negative for estrogen receptor, they are negative for HER2, so the drugs that we use to target the estrogen receptor and target HER2 are simply useless in these tumors. But we're learning more about this cancer as well. In particular, we're learning that this cancer tends to be the cancer where genetic cancers, where inherited genetic cancers by and large hang out. That's going to turn out to be very important because some of the new therapies that we have coming down the pike are drugs that are specifically aimed at those inherited mutations that are driving the growth of those triple negative breast cancers. And my suspicion is that the first of these drugs will probably be approved by the FDA in the next couple of years for patients with advanced triple negative breast cancers. Finally, from a therapeutic standpoint, cancer therapeutics, not just breast cancer, but cancer therapeutics in general, are going through a huge revolution right now, and one that I think was unexpected 5 years ago, but is proving to be certainly one of the more exciting things in my life. And this has been the revolution in terms of our understanding of the immune system and its role in terms of human cancer. Throughout most of my career, when I would sit down with a patient with breast cancer, and the patient would ask me, is there anything wrong with my immune system? I've got cancer, there must be something wrong with my immune system. My answer was always no. My answer was, you know, if you and I are sitting in a room with someone who's got the influenza virus and that person coughs on us, we both have the same likelihood of coming down with the flu and getting sick. In fact, I'm probably more likely to come down with it than you are, based on past history. And so I would say, well, your immune system is just like mine, okay? Well, like many things in my life, I was absolutely wrong, okay? And what we've learned in recent years, and I think this is a particularly important and exciting discovery, has been that if you look at how cancer cells interact with immune cells, what are known as T cells, the body's system for fighting off cancer, cancer cells have proteins on their surface that when a T cell comes along and tries to attack a cancer cell, these proteins actually signal the immune system, go away, don't bother me, I'm not a problem. Okay? All right? I could go into the jargon for the names of these, but just think of this as the cancer cell having a signal for the immune system that tells the immune system to go away. Why is that important? Well, it turns out we can develop drugs, predominantly antibody therapies, that will go and block that signal. And so what happens now? Once you block the signal, suddenly the T cell, the immune system goes, oh my God, there's a cancer here. Okay? And in a number of human cancers, predominantly lung cancer and melanoma have been the leaders in this, we're now able to see that activating the immune system allows some patients to go into prolonged remissions. So for instance, there are patients with metastatic melanoma where the median survival 5 years ago was 6 months for metastatic disease, where there are now patients who are alive with metastatic disease and perhaps cured of their metastatic disease somewhere in the range of 5 to 10 years out from diagnosis. I don't know that this is going to be usable for all breast cancers. My suspicion is that it's going to be usable for actually probably for the most dangerous breast cancers, the ones that are the most highly mutated, because our early data would suggest that those are the ones that are most likely to respond to immune therapies. But what I can tell you is that we've barely scratched the surface in terms of being able to interrogate the immune system and to turn it on to killing off cancer cells. And I in particular, in this area, look forward to a huge amount of excitement in coming years in terms of novel therapies for patients with advanced breast cancer. Now, underlying all of this is research. As a cancer researcher, I've devoted my life to trying to find new therapies for the treatment of cancer. I've done that both in the laboratory and in the clinic. I believe ever so much that research cures cancer. That if we are going to cure this disease, that it is important that we, as a society, put huge and increasing resources into the treatment of metastatic breast cancer. Okay? We need to take this disease seriously. I find it criminal that this is a society that spends more money on tobacco products than it does on cancer research, okay? I find it shameful that the budget for the National Cancer Institute has not increased in an entire decade. Think about that. By the way, that means for practical purposes that adjusted for inflation, we're spending 30% less on cancer research than we were a decade ago, okay? That's shameful as a society. This is only a disease. This is only a disease. I believe that very strongly. You know, the human race has been able to cure a lot of different diseases. There's nothing particularly mystical or magical about it. You have to understand the disease. You have to understand what makes it tick. You have to do basic research in the disease and understand it at a very important basic biologic level how to thwart the disease. You then have to take those findings that are done in the laboratory and move them into the clinic. In the clinic, you have to do appropriate clinical trials in the right populations of patients to make sure that the drugs that look so promising in mice also will look promising in humans. You have to do those trials in an ethical fashion with the informed consent of patients. And by the way, as an aside, I don't think there are any more courageous human beings on this planet than the women who sign up for clinical trials of new drugs for metastatic breast cancer. You then have to take those agents and make sure that once we have proven that those drugs work and understand how they work and understand what side effects that we have to deal with, that those drugs are actually used in our society. As a physician who cares for patients with metastatic breast cancer, but also as a citizen of the society, one thing that terrifies me, and I know terrifies many of my colleagues, is that the astonishing increase in the price of drugs that we have seen in recent years is putting us at real risk for being a two-tier society in terms of health care. One, a fairly small tier that can afford drugs that cost $10,000 a month, and one, which is most of the rest of us, which cannot. So I have sometimes heard people say, I want all of our money to be spent on cancer research and none of it on all that other stuff. My philosophy of life is pretty straightforward. Why do women die from breast cancer? They die for two reasons. One is bad biology. We don't understand enough about how the cancer can kill a patient. But the other is bad access, where we have therapies that can cure patients, but those patients are not allowed to receive the cure because they cannot access the appropriate therapy in a timely fashion. Again, I think that's shameful when that happens. So going forward, what do we do? I think first, all of us in this room, you're all here today because you actually believe that we should be making real progress in this disease. You believe that we should be developing therapies that are both more effective but also at the same time perhaps kinder and gentler therapies for all patients. You believe, I trust, that these therapies should be available to all of your sisters who have the disease, not just in Los Angeles County, not just in the great state of California, not just in the United States, but perhaps throughout the world. Hopefully you believe, like I do, that this is a journey well worth taking, that this is a journey in which we will ultimately succeed, and which it's a journey that's well worth participating in. As a physician, when I go into the clinic with a patient, my responsibility is to the patient who sits in front of me. My responsibility is to care for the woman who I take care of. As a cancer researcher, I feel that I have a broader responsibility, and that responsibility is to all the patients around the country and to the society in which they live. I would hope that as we go forward, that society, that large research enterprise will allow us to get ever closer to where we want to be. Now, I started with a story, so let me end with a story. It's not a breast cancer story, but it's again one of those things that you learn from your patients as a physician. When I was a medical student, I was in New Orleans at Charity Hospital, which is anyone who's ever been in New Orleans will know was the old county hospital, which got trashed by Hurricane Katrina. And I was speaking one day to an elderly African-American gentleman who I, as a medical student, was doing my best to take care of. And I was sitting on the edge of his bed, and he leans over to me and says, "Dr. Sledge, I knows heaven's my home, but I ain't homesick." And I suspect most of my patients believe that as well. And so while it may ultimately be our home, and it may be where patients with metastatic breast cancer ultimately go, like that patient, I suspect most of you are not homesick. Thank you all ever so much. It's been a delight talking to you.